There's no volume. It's talking now. There's no volume. It's all cancelled out. Everything's cancelled out. What did we do wrong now? No, we didn't do anything wrong now. They're introducing everyone, but there's no volume.
A warm welcome on this Wednesday evening. I am Neena Mistry from Shivdev Training Academy. We have always prided ourselves in taking seminars across Gauteng to serve as health professionals for their much needed CPD points. Changing circumstance has now allowed us to reach out to even a bigger group nationally. What an amazing turnout for this evening! We are grateful to Reitzer Pharmaceuticals for their sole sponsorship and couriering a free gift for every person that has registered. There is a live broadcast on Shivdev Training Academy YouTube page. So please allow me to welcome Marika van Linden to do the honors and introduce the speakers. Thank you.
Dear doctors, a very warm welcome from myself, Marika from Reitzer Pharmaceuticals. Thank you for joining us this evening on this lovely webinar. We have two excellent topics lined up with two excellent speakers. But before I briefly introduce them to you, first of all, I would like to say a word of thanks to our hosts, Shivdev Training Academy, for making this event possible. We will be streaming this event live as well on the Shivdev YouTube channel. First up will be our first speaker, specialist dermatologist, Dr. Newaj. He is very well known to our GP as well as Derm Society community within the Gauteng and Pretoria regions, with him having 3 practices in the Gauteng region and 1 in Pretoria. He has also established a very firm footprint on the shores of Mauritius, where he does advanced skin treatments. He has also established a good support structure and ever-growing footprint on the social media platforms to the likes of YouTube channel as well as Facebook live streaming. He is no stranger to this platform. Our second speaker will be pupil advocate Vanessa van Niekerk. She is a member of the National Bar Council of South Africa, as well as a member of the South African Medical Legal Council, SAMA. She practices as an independent mediator, including court-annexed mediation. Furthermore, she specializes in medical law, family law, labor law, as well as insurance law. Thank you and enjoy the evening.
Hi, good evening, everybody. Can you hear me? I want to talk about ethical dilemmas in the management of diseases in our context. I do not do ethics talks very often. As I'm a clinician, I deal more with clinical cases, and over the years, I've seen more than 100,000 patients. However, I believe that a little bit of ethics here and there is very important, and also to discuss our South African context, what we see and how it differs from other countries and our unique problems. Next. So the origin of our rules, our ethics, it started around 4,000 years ago. That's when it was first recorded. Appropriate behavior of physicians were recorded in the Code of Hammurabi. After that, there were many other codes and rules that ensued. However, the oath that is adopted by most medical professions are the Hippocrates Oath. That's what we take once we finished our 6 year of medicine or 5 year of medicine. Some of the original rules do not apply in our current society. There are 6 main principles of medical ethics. First, we need to act in the best interest of the patients. That's where it can be a little bit challenging for all of us. We should not do any harm. The patient has a right to refuse or choose consent, who gets what treatment on merit of illness, and then dignity. Patients and doctors both have the right to dignity. The patients deserve to know the whole truth about the illness and the treatment. So these 6 principles are very important, and we can apply it in different ways and means. Next. So there are many rules that we need to abide to. There's not only the Hippocrates Oath. There are the Medical Council Oath and Medical Council rules, the HPCSA. All the medical societies that we belong to also have their own rules. We have to also abide to medical aid rules, rules of the clinics and hospitals, the laws of the countries, and the tax rules. Now, some of the rules can be different from the others. I'll give you an example. Like the HPCSA says that we are allowed to charge patients if they cancel within a few hours or 24 hours, if they don't pitch up and don't cancel within 24 hours. However, the medical aids don't approve that. So the rules also are not uniform across the different bodies. So we have to reach a balance among the different bodies that we belong to. Next. So what are the rules here for? The rules are there to remind us of our ethical obligations, provide standards and guidelines for adherence, provide medically competent service with compassion and respect for human dignity, not to abuse our dominant position, to take advantage of patients sexually, and not to exploit patients in financial or business matters. We must not force patients to buy our products. If we sell certain products or we have a pharmaceutical company, we must never force patients to buy only our products. We must always give them different choices. Next. So our obligations, our relationships are based on confidentiality, trust, and honesty. We must not decline or accept patients solely on the basis of race, color, gender, sexual orientation, religion, or national origin. We must provide reasonable explanation of the etiology, treatment, and progress of their disease. Next. So we have ethics committees and we have the HPCSAs. A lot of time people who work and sit on these committees, they've never worked in the private. It is very difficult sometimes to explain to them what goes on in our private practices. And we have to try and explain, and they don't understand everything. So I will focus on what we see in our private practice and discuss with you guys. A lot of you will identify, and you can add and share and discuss with us later on at the end of the presentation. Next. So the things that we're going to go through are the background of patients, the differences in culture, literacy, language, the different patients with cash, medical aid, public sector, which one is the better choice, transport and size of our country, how it affects us, our open porous borders, and also no control on pharmaceutical companies in our country. Next. So also the other factors that can affect our practice are the availability of electricity, non-compliance, availability of medications, pharmacist incompetence, and a lot of use of alternative medicine. That has become a big thing nowadays. Next slide. So the background of our patients, we have a big divide in this country. We get from the poorest of the poorest to the richest of the richest. So we get patients from different backgrounds, and it's very difficult to give the same treatment to everyone. You want to prescribe medication, but they cannot afford it. You have to understand the background of the patients. What do they do? Can they afford the treatment? They may be able to afford the treatment for a month or 2 months. After that, they can't afford. So we have to make sure that we not over-prescribe, not under-prescribe, and also make sure that the patient will be able to get the medication. Just giving them a prescription is not always enough. We need to see if the patient will be able to get the medication and treat themselves. It is also very difficult to do blood tests as prescribed per international guidelines. Sometimes we have to limit our investigations, limit our tests, and go with our clinical knowledge. Maybe it's right, maybe it's wrong. Some of you will agree with me, some of you won't, but we have to do our best to limit the cost to the patients that can't afford. And in the same way, we have to treat them and get them better. So this is a big dilemma for us, how to limit the cost and how to treat them with their available resources in the country and also their pocket. Next. So there are major clinical differences between our model and Scandinavian model or Russian models. A lot of our members, SAMA members or our ministers, they go to foreign countries and they try to gain knowledge from their background, but it cannot be applied to our context. We have a unique context in South Africa. In those countries, they have unlimited resources. They have different type of people, different skin colors, and different beliefs. And we have to forge our own way forward. Lots of people go overseas, lots of our representatives go and they want to implement their medical center, their medical way of doing things. Unfortunately, it doesn't work. Our patients can easily get offended if you attend to somebody else of different race before them, even if it's an emergency. We have to even take that into account in our context. If you go to another country, patients of one color, and you can attend to any patients actually. We have to be very careful what words we use when we treat patients or when we speak to them. We can't just say anything. So different people get offended with different things. They have different beliefs. And that must come into play when we treat patients. Next. So there's also a big literacy and language barrier in our country. There's a high rate of illiteracy and various languages are spoken. Even in Gauteng, there are people coming from all over, and different people don't even understand when we speak to them. We have people from all over the world. We have people from China. They come see me and they don't even understand English. People from Bangladesh. So it becomes very difficult sometimes to communicate and to give them exact instruction what you want them to do. Even to explain their condition properly can take you a very long period of time to explain to them. One of the examples of people from Mozambique, sometimes it can take you half an hour per patient to see somebody from Mozambique because of the big language barrier. It's not only people from our country, but we see people from all over, and that becomes a challenge for us. Most times they act as if they understand, but later on they get confused. Sometimes patients, you're seeing the patients, they are in their WhatsApp, or they don't pay attention, or they take a phone call, and then after they leave the practice, they give a phone call to say, but the doctor never explained us how to take the treatment. or the doctor didn't give any medication when you've given them a prescription to go to the pharmacy. And this problem seems to be more common in the younger population than in the older population. The younger population seem to have regressed. They seem to have moved backwards. The older population seem to pay more attention. They have more respect. They listen to the doctors. So this is a challenge that most of you will get, and you can share with me at the end of the presentation. Next. So the cash, medical aid, and public sector, which of the three is the best to belong to? Now, patients that pay cash, patient can pay for consultation, but then they don't have any money to pay for medication or investigations. Most of the time, we have to see the patient, when you ask them, please go get this medication, they believe that you're going to dispense the medication. Then most of them don't even have money to go buy the medication. Sometimes you need to do tests, and the patients just don't have the money to do the test. So you have to go with what you see. You have to do clinical diagnosis without doing investigations. We are not like Dr. House in America that can do hundreds of investigations. So sometimes we do our best. Actually, most of the time we do our best with what is available to us. Lots of patients come see us, they pay for the consultation, and that's it. They don't have any other resources. Then they can't go get their medication, and maybe by just seeing us, they think that they will be cured. According to me, medical aid patients are the worst off, as the day-to-day benefits hardly cover 1 to 2 months of treatment. Most of the medical aids do not accept diseases into the chronic, and most skin diseases are chronic, so they can get medications only for 1 or 2 months. In public hospitals, actually, they end up getting much more medication, and it's much cheaper for them. Cash patients tend to be better than medical aid patients because lots of them tend to have a bit more disposable income to use. So according to me, the public sector is the best. The cash patients are second, and those having medical aid are worse off in the majority of cases. As for skin treatment, some of the treatments can cost between 5,000 to 20,000 Rand per month, and medical aid do not cover them. Sometimes I have to think twice. Can I tell them approximately how much it will cost? Some people I see, the background, they've put there, they are general managers or CEO. When they go to the pharmacy, they give me a call, look, doctor, the medication is costing me 3,000 Rand and I cannot afford it. Can you change the medication? And it becomes very difficult to give alternatives. It is morally challenging whether one has to admit to patients or ask help from other specialties to help cover the medications. What happens in dermatology sometimes is some of the medications can be approved by other specialties like rheumatologists, but it's not approved by dermatology. If you're a dermatologist trying to motivate with medical aid, it's not approved. So should we ask a rheumatologist to accept it, to try and motivate for the patient, or should we admit the patient in hospital and do certain investigation when they don't need to be admitted? I'm not sure. Some of you can tell me, give me an answer to that. It is very common practice in other specialties to admit the patient to do a CT scan when it could have been done as outpatients. Sometimes, from a few years ago, we noticed that several patients come to us and they say they've seen me before, and when we ask them what is their name to get the file out, they don't seem to know what name they used before. At first it was amusing to us. We thought, the patient can't even remember their own names. But afterwards we realized that no, these patients actually may have used other people's medical aid to come previously to see us, and now they can't remember whose medical aid they've used. So this is quite common practice. It's difficult. Sometimes you catch the patients, but If you catch the patients, what do? Do you go report them? Do you give them medications? Or you just do as if you ignore them? That also becomes a big dilemma. And sometimes it's better not to catch the patient because you're trying to treat them and get them better. Next. Transport. This has become a major problem. Lots of patients come from far, so we don't just see a feeder area. The patients can come from different provinces, and sometimes they need to come for their appointments, and there's a poor transport service, or there are strikes, and they don't end up pitch up. They don't pitch up for their appointment. They have no transport to collect their medications, and they cannot even perform blood tests. Sometimes they pitch up, they haven't done a blood test, which is very important for me to give them another 6 months of repeat. So what do you do in that respect? Do you send them away? They stay in Limpopo, they've come to see you, and they need to go back. So this is also a dilemma. Should you just prescribe it and just do the blood test and give them a call? Or what do you do? So lots of patients, this is a major challenge in all our practices, and it will apply to all of the patients and all the doctors as well. Next. Our borders. Patients are constantly moving into South Africa, and we as dermatologists, we have seen a few leprosy cases because a lot of patients are coming from countries like Mozambique where there is leprosy. So a lot of patients are bringing diseases from other countries, and some of them we don't have that much experience in. And we have to treat these patients. They come from other countries with very severe cases. And I've heard in some of the public hospitals, 33% to 40% of patients are from other countries. And this tends to burden our public sector quite a lot. In the private sector, it's a very big challenge as well. You see the patient, they can't communicate with you properly, and then you give them a prescription, they can't do a follow-up in a month's time as needed. So you will probably see them in 6 months to a year's time. Also, if they go back to their country, they can't get the medication there. So it is a challenge to see patients from another country, but we have to try and adapt and do with what is possible in our practices. Next. Hygiene and electricity. Lots of our patients have poor housing conditions. They don't even have sewerage facilities. And this can lead to skin infections in atopic patients. Patients with atopic eczema tend to fare very badly if they have very bad if they don't have running water or they don't have electricity. A lot of them, they have mixtures done for them, and because they cannot refrigerate their products, these mixtures end up getting disintegrated within 1 to 2 months, especially in warm weather in the November, December time. So patients pay a lot. They come and see a specialist or they come and see a doctor, and afterwards they get their medication and then they cannot refrigerate it or they cannot use it the way we've prescribed. And after a few months, they come to see us, they haven't got better. So they wasted a lot of money, and we cannot do much about it. We just try. We can only try our best. Next. Compliance has become very poor in our patients, especially the younger patients. You give them a 3-4 month prescription, they take it for 1 month, and they come back a year later, they haven't improved at all. Poor compliance is the #1 cause of treatment failure in a dermatology practice. They don't follow the instructions. You can sit and explain to them, but they would not listen to you. They will try, when you tell them to use, do not use it on your face. They will use a steroid on the face because it works quicker. Or their peer has told them, look, use this cream, it will make you become fairer. And they tend to use it the wrong way, and then they come back with lots of complications. They use very little amounts sometimes, and when they have to follow up in a month's time, they sometimes bring the full tube and show you. And then you see, they tell you, look, doctor, I haven't got better. Your medication is not working. When you look at the tube, it's 80% full. So they haven't applied the proper quantity. They follow up only when the conditions become intolerable again. So you tell them come 1 to 2 months later for follow-up. They don't pitch, they are much better, they improve, and then they come back again 6 months later when the condition has deteriorated completely. Then you have to again start very strong medication. Again, you have to give 5, 10 medication to them, and the cost is much more because now you have to give them all the strong things to get them back on track again. And they just don't understand that they need to follow up within 1 to 2 months. It's not like Europe where when you tell a patient to come, they tend to follow up with you, they get their medication and you get a good result over a long time period. And most of the experienced doctor will pick up that patients lie. All the patients will tell you a story if they don't use their medication, or they will tell you, nowadays it's the coronavirus, I didn't follow up because of the coronavirus, or you were closed, or you didn't have any appointment for the past 2 months when your waiting time is only 1 to 2 weeks. So you can easily pick up that patients are lying to you. At first, I used to answer back to them. I used to say, no, this is a lie. Nowadays, I pick up the lie, I just ignore it because it's no use. You're never going to change anything with these people. The next slide. As for investigations, a lot of diseases need to have further investigations. We dermatologists, we tend to do histology. We do some blood tests. However, we have to do very limited ones as outpatients because it tends to eat up all the medical aid if we want to do it properly as per international guidelines. We have to choose the most important ones and work on our clinical examination. When we do medicine, we are told that 80% of our diagnosis is done by history only, and 20% is by clinical examination. In our case now, in practice, what we see is we can't get a proper history. We can do an examination, so we get some idea what's going on, but we cannot do investigations easily, as they don't have any budget, as they don't have any budget for investigation. So we are very limited, and we have to, most of our diagnosis is limited to clinical examination. So if we overdo it, they won't have any budget to buy any medication. Then they will come back to you and they'll be very angry. Some patients insist on investigations because they've seen it in movies, they've seen it in people talking about it, but then when they get the lab cost, they become very angry. Patients have the right to ask the laboratory how much it will cost for the investigation, but us doctors do not know the exact prices for these things. So that can be a big challenge as well. Is it acceptable to admit patients only for minor blood tests? Some patients have asked me to admit them. Personally, I don't think it's acceptable, but some doctors do it. I'm not sure if it's ethically right, but I cannot judge the doctors because I know that it's a very big challenge with patients, with a budget. And if you're trying to get somebody better, you will try everything possible in the books. Some tests are done to appease patients. I've seen some of my colleagues try to do a few tests because, like especially patients want to know if their child is allergic to something. Now, most of these allergic blood tests are not of any use, but they insist with their GPs to get it done. But then when they get the bill of 3,000 Rand and they have to pay from their pocket, it becomes a big deal to the patients. Next slide. Telemedicine. Telemedicine has been around for a long time. And some of us have been encouraged to do telemedicine because of coronavirus, but is it acceptable in our setting? It is a very big challenge. When I try to do telemedicine, I cannot get I cannot see the patient in front of me. I cannot get a full idea how the patient looks, what is the distribution of the disease. I've read some articles where patients are doing telemedicine, but they are in shopping centers, shopping, and the doctors are sitting in the offices. So the patient couldn't come to the office because of coronavirus, but they are shopping in shopping centers, and that's where they're communicating with their doctors. I think if the more you offer the patient, the more disrespectful they become towards you. Technology becomes a challenge for us. Lots of time when we're trying to do telemedicine, we cannot see the skin rashes, or we cannot hear the patients. It takes much longer to see the patients, or the patients have much longer stories. And when there's one consult, a lot of time they want to put the whole family, 4 or 5 consults at the same time at the price of one. And also it's a big challenge to get our fees. So the patients don't pay. The medical aid may not pay. Some of us have had challenges in getting the medical aids to pay. So some doctors accept to do telemedicine, some don't. You can give your opinion at the end of this presentation. Next slide. So nowadays, Google doctors, patients seem to know a lot from Google. I've had patients who come and tell me they are much better doctors in Google than me. So they think my treatment is wrong and I must change the treatment according to what they saw in Google. I've had it last week itself and I refused. And they come in, they say, no, my training is not enough. What they've seen in Google makes much more sense to them. They get very angry if the treatment differs from what they saw in Google. The best option in this case I've seen is to give back their money and ask them to see somebody else. Cut them short, don't waste your time with them, as you're not going to win with them. These patients are never going to be happy, and let them go somewhere else and let them be somebody else's problem. Because of these Google things, I myself have stopped email service because they go home, they consult, they get all their answers, then they see something from Google and they send you 10 emails one after the other. And if you don't answer it, it becomes a big problem. They keep on phoning and harassing us. So some of us offer email service, some of us offer social media service, but it becomes a big challenge because patients abuse these and they disrespect the doctors much more. Next, please. Emails, again, if you have email service, patients just drop an email. Today I've had an email 3 years ago, a patient saw me. They don't need anything much, they just want a prescription for what was given 3 years ago. I can't even recall the patient. So, and if something goes wrong, the same patients are the first that tend to sue the doctor. So if you've not seen the patient, they send you an email, they just want a prescription, you give them the wrong thing, you just repeat it and they have an underlying infection, something goes wrong, then it becomes a major challenge for yourself. They will come back to you and say, why didn't you refuse to send them an email? Why did you accept to give them the prescription? So it becomes your own problem. So be very careful in sending email prescription to patients. You think you are being nice to them, you think you're going to keep the patient. These are the patients that may give you problems in the long run. And most of the time, those that needing emails are not patients from overseas or those that are the real needy ones. Those are the patients who can afford it, who are going on holidays overseas, who are going to Australia, New Zealand, and they just don't want to come and pay for a consultation. They just don't want to come and sit or spend time. They just want they've paid once in their lifetime. They think that now they're going to get this service till the rest of their life, they're going to get it for free. That's what they think with us doctors, that we're going to offer them a service for free till the rest of their life. The same patients, when we refuse to give them an email prescription, they say, no, their medical aid is finished. So we tell them, okay, there is a public sector, they can go and get the treatment. And they absolutely refuse to go to the public sector. It's as if a big insult for them when we mention the name of the public sector. They start being rude and disrespectful to our frontline staff. Again, like I said, they use the COVID-19 as an excuse for repeats, but they are spotted in shopping centers, or they are on social media. They are all over the show, but they just don't want to come and get the treatment. And the excuse is happening on a day-to-day basis. It's happening every day. Next, please. Pharmacist incompetence. We're having this again and again. It's happening more in the big chains like Discam and in Clicks, where the pharmacies are circulating very quickly. The younger pharmacists, I'm not sure where they're obtaining their degrees, but they don't perform the mixtures properly. And lots of them phone us because they cannot calculate. They can't even calculate 25% salicylic acid. They don't know how to do these calculations, and they phone my practice and disrupt my practice to ask me how do they do the calculations. So this has become a major challenge. They don't know how to advise patients how to use their medications. And patients are not even told to come for the repeat medications. Maybe some of them are told, but they just ignore it, and they just put the blame on pharmacists, but a lot of time it's a pharmacist themselves that are wrong. And I've seen a lot of wrong doses being given by the pharmacist. You give the patient a certain dose, the patient has given a different dose of the medication. And it confuses the patient and it creates a lot of problems. And that's when we get patients who cannot take the medication properly and they don't get better. Next, please. Pharmaceutical companies also ought to be blamed in availability of medications. A lot of medications are exorbitant in prices, especially if there is no generic. The same medication I've seen overseas are 2-3 times cheaper. And it's the same pharmaceutical company that is marketing it overseas. In South Africa, they monopolize the market and use various strategies to keep the prices as high as they can. And once the price of certain medications come down, they stop importing it. And patients are forced to use newer ones, which are more expensive and less effective medication. Lots of time, the cheaper medications are out of stock. I don't know if it's a truly out of stock or they just don't bring it because they don't make much profit from them. So pharmaceutical companies use various strategies, and lots of time patients go get the medication and it's out of stock. Then what? Then they phone the doctors, they want different prescription, and it causes a big confusion for the patient. Next, please. Yes, alternative medicine, as I mentioned it before, it's gaining a lot of popularity in South Africa and all over the world. I just want to add that patients with medical aid, they expect the medical aid to pay for emollients and sunscreen, and it becomes a bit more difficult for us. I forgot to mention this point before. However, as alternative medicine, at one stage I had at least 2-3 patients every day that were trying marijuana oil for everything. They had skin cancer, they're using marijuana oil. They had eczema, they were using marijuana oil. It became such a big problem in my practice. And sometimes I had to tell them maybe they must try it for a while and see if it's not working. Maybe they must use the medication that I'm prescribing. It is being found more and more that the effect of marijuana is not as good as it was first, the hype that happened. So I don't refuse them. If they think that it's going to work, I tell them try it first. If it doesn't work, please use Western medicine, use the medication that have been prescribed for them. Almost everybody has been to alternative medicine practitioners for skin, And almost everyone who's been to alternative medicine practitioners, especially homeopaths, for their acne, for their eczema, they've been told that they have a liver problem. I'm not sure how these degrees are done in these countries. I've met a homeopath who told me she did 3 years as online, and she's using the title doctor now. So almost all the problems, if you see they've been to a homeopath, anything, blistering disease, skin cancer, it is a liver problem that has caused that, and they need to cleanse the liver. So just be very careful. And when the patients go to alternative medicine, some of them make them do a lot of blood tests for even conditions that no tests are warranted. And the patients gladly pay for these tests. But when they come to us, they squeal. They just don't want to spend the money on the test because they've used up all the money somewhere else. That's one of the problems that we're seeing more and more. Next slide, please. So there are so many dilemmas, so many challenges that we see in our practices, and many of you will identify in your own practice. Some of them may be a bit different to what I've said, but I would like you to comment, I would like you to discuss and share it with us. And it will be great for us doctors to come together and share our experiences. Thank you.
Thank you, Dr. Newaj. That was a very informative, lovely talk, very knowledgeable. I would like to just extend the invitation to ask for questions. I just want to see if there's something popping up on the chat box. Please utilize the chat box. If you have any questions for Dr. Newaj, please type them now, and we can just relay straight to him, please. We will just allow a minute or two just to see if there's any questions coming through. Perhaps while we wait for the questions to come through, there's nothing as yet. Chintan, if I can ask you just to maybe put the video infomercial on for the moment while we get some questions together. Doctor, I see there's no questions coming through as yet. Just a remark to say great presentation and that everybody can definitely relate to that experience as you've explained in your talk. I'm going to ask Dr. Newaj to please perhaps just in the chat box type your email address for the doctors, so when they do have any questions, maybe afterwards they can converse with you directly on email. I see there's one question coming through from Imran Jetham. How did the patients get to use someone else's medical aid without your knowledge? Did you not check ID and cross-reference with their medical aid card?
Sure. Most of the time, it's children. So children, when they bring the children, they can bring somebody else's child or their niece or nephew. It's very difficult to know because children don't have an ID. They don't bring their ID. We don't check. So it's very difficult for us to know from children whose child we're seeing if it's really the patient's. So, and also we end up picking that up a bit later on. We didn't pick it up at the beginning. Later on, we realized, no, that wasn't the child that was seen by us.
Thank you, Doctor. There's another question from Rupesh Daya. What can be done for an elevated ESR that is caused by isotretinoin?
Isotretinoin. ESR is not supposed to increase by isotretinoin. It's not one of the tests we do often. We usually test for LFT and triglycerides level. So a raised ESR, you must try and see if there are other causes for it. Usually, as doctors, we act on a raised ESR only if it's around 10 times the normal value. Then we can stop the isotretinoin if ever it's related to it and see if it comes down. However, if it's just slightly raised and we're not sure if it's isotretinoin or not, continue the treatment. Even if LFT is slightly raised or triglyceride is slightly raised, continue the treatment.
Thank you, Doctor. There's a question from Jade Hughes. With regards to cancelling or non-show of patients, are you allowed to bill a patient for non-attendance in a public setting?
I'm not sure in a public setting. What do you mean? I work only in private sector. You can't, public sector is different. Maybe what you're trying to say in the private sector, I can answer you. According to the HPCSA, specialist is allowed to bill if it's not cancelled at least 24 hours in advance. I think for a GP, I think 3 or 4 hours in advance. We are allowed to, but the medical aid do not allow you to, they don't allow you to claim the money. So it's very difficult when you send them a bill. I've tried that. The patients would never pay you. So it's a very, very, very difficult thing. Yes, the HPCSS says a provision with it, but you're not going to get your money. We're not covered.
Are there any more questions for Dr. Newaj?
Currently, no.
If there's no more questions, Doctor, thank you very much. We really thoroughly enjoyed your talk. As I said, Doctor did post his email address in the chat box for those of you that want to email and converse with him afterwards. Thank you. We will hand over to our second speaker after we have a comfort break, a couple of minutes, so you can just stretch your legs, just refresh a bit, and then we will get back to our second speaker, Vanessa van Niekerk. Thank you, Chintan. I think if everybody's ready and settled in, we can hand over to Vanessa van Niekerk to start with her talk. Vanessa, if you are ready, you can
I'm
start.
ready. Okay, good evening, everybody. I'm going to try and give you some information in terms of medical intervention in the law. And it's quite interesting that Dr. Newaj and I did not even have a chance to see each other's presentations, but mine links quite a bit to what he had to say today. I just want to ask the host to enable me to share my screen. Then I can start with the presentation. Chintan, there we go. Okay, I've made notes for myself to make sure that I don't run around or run away like a freight train like I did last time. So I'll just give you some time to actually absorb what I'm saying. Okay, medical intervention by its nature is an infringement of a person's rights. Surgery is a procedure where a patient is made unconscious, cut open on a part of the body and sewn up again with a needle and thread. You can equate this to a physical attack where a person is hit on the head, made unconscious and then stabbed with a knife. Goodwill and motive does not automatically change the unlawful action into a lawful action. So how then do you make an unlawful action lawful? You do it by way of contract or consent, or more specifically, informed consent, which is a prerequisite for medical intervention to be lawful. Now, what if consent cannot be given? There are other grounds of justification. Now, justification means making something justifiable. In other words, making a wrong a right. So justification, which would make a medical intervention lawful, even without the informed consent. And we discussed a few of these aspects on a seminar the other day, and people were not quite sure how self-defense fitted in with regards to the medical practice. However, I've seen in practice how doctors have actually physically been abused, and not intentionally by the patient, but by way of head injuries and that type of thing. So reasonable defense against an actual imminent unlawful attack, that would constitute self-defense and would be applicable in terms of medical law. Negotiatorium gestio, that is acting on behalf of another person in the best interests of that person. Our law recognizes that in some instances it is impossible to obtain consent, and that is when a patient is unconscious or needs life-saving treatment. There must be the requisites for that, though, is that there must be an emergency which necessitates the intervention. In other words, there must be an immediate threat to the patient which precludes waiting for consent. The patient must be incapable of giving consent. And further to this, the intervention must not be expressly prohibited or against the patient's will. That would be in the case where we have religious reasons. If the religion or the religious reason is known to us, we cannot expressly act against those wishes of the patient. And the intervention must be intended to be in the best interest of the patient. It can't be a ego-driven thing for a doctor to try and prove a fact. It has to be in the interest of the patient. Necessity. The ostensible wrongdoer is placed in a position through external forces where his or her legitimate interest can only be protected through the reasonable infringements of the rights of another. This is distinguished from negatorium gestio in that the best interests of the patient are not necessarily a requirement. And the broader consideration of society may be relevant. Emergency exists or is imminent. The medical intervention is in the best interests of society and may thus apply in the patient's against the patient's wishes. It is not a requirement that the patient was unable to consent. So even if the patient was able to consent in certain circumstances, the medical intervention may still be justified because of necessity. Therapeutic privilege. This may exist where full disclosure may be more harmful than non-disclosure. Extreme caution is to be exercised in claiming therapeutic privilege in the interest of protecting a patient. I think an example that a person can use there would be where a patient needs surgery and they were victims of a motor vehicle accident, and the whole family was killed in the accident, and one person survived. That person might not give consent to the surgery should they know that they have nothing to live for, if you put it that way. So statutory authorization. Various statutes justify a medical intervention or disclosure of information. Grounds for justification can be found in the common law and in the National Health Act, Act 61 of 2003. The two largely overlap. However, the common law ground of justifications are more flexible and make provision for a greater variety of cases. Section 7 of the National Health Act provides that the health service without informed consent is authorized in terms of any law. So if any law prescribes it, then it is authorized. It says the provision of the health service without informed consent is authorized in terms of a court order. So you can obtain a court order. Often this happens when we are dealing with children and parents are refusing to give authorization. You can, if time permits, with an urgent application, get a court order to intervene. Failure to treat the user or a group of persons, including the user, might result in serious risk to public health. Note that no requirement in respect of emergency is set here. I think here we can probably use the COVID as an example where if somebody has got or is infected and known to be infected, that his treatment would be a prerequisite or would be required in order for, and having him quarantined would probably be the best thing to protect the rest of the people in his vicinity. And further to that, any delay in the provision of health service to the user might result in his or her death or irreversible damage to his or her health, and the user has not expressly implied or by conduct refused that service. In Section 9 of the National Health Act, it makes provision for hospitalization of patients without consent. When such an admission takes place, the hospital or other healthcare establishment must inform the head of the provincial care department within 48 hours, unless the 48 hours expire on a Saturday or Sunday or public holiday, in which case a more lenient arrangement applies. However, this obligation does not apply if the patient gives consent within 24 hours. A court order, medical intervention may be born out of an order secured in court. Medical intervention is prima facie unlawful or wrongful if there is no ground of justification. The medical practitioner exposes himself to liability claims if there is no justification for medical intervention. The following are examples of grounds for sorry about that, I've just lost my place. grounds for being dragged into court. Breach of contract, civil or criminal assault, that is violating a patient's physical integrity. Civil injuria or criminal injuria, which is violating the patient's dignity and privacy. And negligence. Negligence, which is a word that strikes fear into a lot of the doctors lately, with regards to the fact that the National Prosecuting Authority seems to be targeting doctors for negligence now. Consent is another ground of justification. Consent to injury is not only relevant in the assessment of lawfulness or unlawfulness of medical treatment. It can be raised in a variety of situations. The defense is expressed in the maxim volenti non fit injuria, which translates to no injustice is done to him who is willing or gives consent. The principle is an expression of the individualism which is characteristic of a society which freedom of individual enjoys the highest respect. An individual is protected against violation of his interest by others, but law does not protect him against the consequences of his own convictions or his own voluntary acts of heedlessness. So let's look at the requirements. We'll take a closer look at the requirements for what valid consent entails. In order for medical consent to be legally valid, the following must apply. It must not violate good morals of society. And good morals mean that the prevailing attitudes of society are what kind of conduct is lawful and what is unlawful or wrong. This is also a difficult aspect in terms of ethics, because again, this is born out of what perceptions are, what in a person's perception is good morals, and what is the prevailing attitudes of that specific society. So against good or bad or violating good morals can sometimes be a tricky position to be in. Valid consent must be given in proper form, where such form is prescribed by law. Consent may be express, which is oral or in writing, or may be implied by the patient's behavior. In medical law, implied or tacit consent is the rule rather than the exception. Legislation does, however, sometimes require written consent, such as cases in sterilization, surrogate motherhood, removal or withdrawal of tissue, blood or gametes from a living person for medical or dental purposes, child's consent to an operation, virginity test, circumcision of a child, abortion, and the donation of a gamete. Voluntary, that means that consent must be voluntary and it must not be obtained through fear, violence, or force and fraud. It must be clear and unambiguous. It must be comprehensive. Consent must cover the whole transaction, including any foreseeable consequence and the material risks involved. Elements which are to be included is knowledge, appreciation, and acquiescence, in other words, acceptance without protest, and must be given by a person legally capable to give consent. The age of consent in medical matters may be as low as 12 years of age. You have to take into consideration, though, the child's ability and capability of understanding and maturity to make such a decision. The best and most relied upon defense for the medical practitioner is informed consent. Pertinent acknowledgement and acceptance of informed consent into SA law was established in the Castle versus de Greef matter. I'm just going to give a short summary as to what happened there. And deciding whether a medical practitioner has incurred liability for negligence as a result of his failure to warn his patient of the material risks and complications which might arise from surgical operations or other medical treatment. It is for the patient to decide whether he or she wishes to undergo an operation, and it is in principle wholly irrelevant that the patient's attitude is grossly unreasonable in the eyes of the medical profession. The patient's right to bodily integrity and autonomous moral agency entitles him or her to refuse medical treatment. It would be equally irrelevant that the medical profession was of the opinion that it was in given circumstances in which the surgeon's duty to refrain from bringing the risk to his patient's attention. Thus, in the South African context, the doctor's duty to disclose a material risk must be seen in the contractual setting of an unimpeachable consent to the operation. For consent to operate as a defense, the following requirements must, among others, be satisfied. Consenting party must have had knowledge and been aware of the nature and the extent of the harm or risk. The consenting party must have appreciated and understood the nature and extent of the harm or risk. And the consenting party must have consented to the harm or assumed risk. The consent must be comprehensive, that is, extend to the entire transaction inclusive of its consequences. Accordingly, in our law, for a patient's consent to constitute justification that excludes the wrongfulness of medical treatment and its consequences, the doctor is obliged to warn a patient so consenting of material risk inherent in the proposed treatment, a risk being material if in the circumstances of the particular case, a reasonable person in the patient's position, if warned of the risk, would be likely to attach a significance to it. The medical practitioner is or should reasonably be aware that the particular patient, if warned of the risk, would be likely to attach significance to it. This obligation is, however, subject to the so-called therapeutic privilege, which permits medical practitioners to withhold disclosures which in their opinion would be detrimental to the patient in question. Whatever the ambit of this privilege may today still be in the light of the inroads that it might make on a patient's autonomy. The decision in Castle and de Greef was reserved in part on appeal. So the requirements for informed consent can be found both in Common Law and National Health Act and should include all of the following. This makes it quite difficult for a doctor to give a one-pager informed consent because you need to really encompass every single aspect that we've got here. The nature of it, of the procedure, the scope of it, the consequences, all the risks and dangers, the complications that might occur, benefits of the procedure, disadvantages and prognosis, the alternatives including non-treatment and aftercare. I included aftercare because we've come to realize that a lot of doctors fall under fire because of the fact that patients say they did not expect the extent of discomfort that they had experienced after this procedure, and that might have made a difference in their decision. The expectations versus the reality. Patients sometimes have very unrealistic expectations and the reality falls short from what they expect. And that also often causes a point of contention. I've put in Q&A, and that also in a sense is difficult often for doctors to be able to get to that point, because a lot of the patients have a lot of questions and sometimes seem very irrelevant, but for that patient and at the end of the day, for the doctor's greater good as well, it would be very advisable for a doctor to engage in a question and answer session with a patient. I know it takes a lot of time, but at the end of the day, it might be a good option to look at, even if you put a short Q&A on the informed consent form and perhaps contact the patient afterwards to deal with the questions that they might have. But like Dr. Newaj said as well, patients often pretend or say that they understand, but at the end of the day, they don't understand. And this sort of clears up that problem that might arise from that. The medical profession is very vulnerable to litigative action in terms of the law of delict, where compensation is sought from patients who are of the opinion that the rights of dignity have been violated. Even frivolous and vexatious claims may be successful where a medical practitioner has not taken enough measures to protect himself. Your biggest and best form of protection in any litigation is your informed consent and your medical records. It is valuable for a medical practitioner to obtain the services of a legal professional in order to identify and help design policies, documents, contracts, and procedures to avoid and reduce the risk of litigation, which is born out of failure to address any of the points addressed in this presentation. So even if it's not anything that you deliberately are falling short of or not attending to, it's not something that you've been geared to focus on because your profession requires you to deal with people and your passion for healing, not for legal aspects of this, which is why it often comes back and hurts the doctors the hardest. In the event of a claim being submitted against a medical practitioner, it is imperative for the practitioner to be familiar with the concept of alternative dispute resolution and the benefits of mediation before litigation. In the 9th of March this year, the High Court rules changed and Rule 41A has become very prevalent, where mediation is prescribed before litigation. So nobody can proceed for litigation until they've attempted mediation. And if they don't attempt mediation, that actually could run into quite a severe cost order for them. So hopefully that will shed some light or bring some light at the end of the tunnel for medical practitioners. I've actually just added an article that was in the Middelburg Observer on the 23rd of July this year, where Dr. Van der Merwe, I think it's quite a famous case, was arrested for the death under negligence for a patient of his during birth. He was subsequently now released. I'll just read out this to you. It says, 'n Middelburg gynaecoloog Dr. Dion van der Merwe, wat in die wyd gepubliseerde verhoor van Dr. Dani van der Merwe getuig het vanoggend gesê, die tersydestelling van die skuldigbevinding en vonnis in die konstitusionele hof, ekskuus ek net hierso, gee hom en ander ginekoloë nie soseer gemoedsrus nie, maar eerder nuwe wetgewing wat vanjaar in die Staatskoerant gepubliseer is oor mediasie. Dr. van der Merwe het nie net ter ondersteuning van Dr. van der Walt getuig nie, maar ook briewe van 14 ander dokters by die hof ingehandig wat Dr. van der Walt se lof as mediese spesialist besing het. Die saak teen Dr. van der Walt wat in eMalahleni gepraktiseer het, is deur die konstitusionele hof terugverwys na die direkteur van openbare vervolging in Mpumalanga. Die saak teen Dr. van der Walt wat in eMalahleni gepraktiseer het, is deur die konstitusionele hof terugverwys. Die saak het vanaf 2006 gesloer na die dood van Dr. van der Walt se jong pasiënt Pamela Daweti, wat tydens geboorte begin bloei en later oorlede is. Dr. van der Walt het teen sy skuldigbevinding en gevangenisstraf van 5 jaar appel aangeteken, maar die appel is verlede jaar in die Hooggeregshof van die hand gewys en Dr. van der Walt het sy vonnis begin uitdien. Hy is 'n paar maande gelede op parol vrygelaat. Dr. van der Merwe sê nuwe wetgewing verplig pasiënte wat klagtes het om eers met die mediasieproses te begin. Indien die hof later bevind dat die regsverteenwoordiging klaar nie erns met die proses gemaak het nie, kan hulle kostebevel teen hulle gemaak word. Mediasiesake duur Mediese sake duur jare en daar is astronomiese kostes aan verbonde. Nou kan dit binne weke met mediasie afgehandel word. Dr. van der Merwe sê, almal maak foute, maar wanneer daar klagtes is, teen 'n geneesheer kan dit vinniger tot bevrediging van alle partye opgelos word. Hy het gesê, alhoewel die saak teen Dr. van der Walt terugverwys is, sal dit geen sin maak om hom weer te vervolg nie. That's also again the double jeopardy that comes in there. He's not going to be pursued again for the same matter, but in future, doctors are not just going to be arrested offhand, and negligence matters when brought to court will need to be mediated first to see if there was a proper resolve that can be found. So yeah, that is my story, and I'm hoping that it was insightful and that it would help you. And feel free to ask me questions with regards to the informed consent and anything that you may feel you need to clarify with regards to medical intervention.
Thank you, Vanessa. That was insightful indeed. I'm sure a lot of the doctors will benefit, and you've guided them quite nicely with the process. But if any of the doctors have any questions for Vanessa, you're welcome to type them in the chat box. We will relay an answer straight away. If not, Vanessa, if I can also just ask you to type your email address in the chat box for the doctors, and then they can converse with you afterwards as well.
Stop screen share.
Thank you. So while we are waiting for questions, if we can ask Chintan to just air the second video infomercial, please, Chintan. Vanessa, there seems to be one question. It's an anonymous question. Will the new POPI Act play a role anywhere?
Yes, I think the POPI Act is going to have quite a big impact on the medical profession. We're going to have to look at how to safeguard doctors. I am busy working with a panel to try and find out what the best practices would be for doctors, but definitely, yes, how your processes and procedures in your practices are definitely going to be impacted by it. I think to a large extent, many hospitals and organizations are actually taking the POPI Act completely out of proportion and overreacting to it. But yeah, there's definitely going to be a role to play in terms of the POPI Act, yes.
Perhaps we can do a follow-up webinar at some time on the POPI Act to give a broader scope. There doesn't seem to be any further questions at this point. So you are welcome, if you have questions, to email them to Vanessa, converse with her directly. I see that Roshni has just posted the link for everybody, just as a reminder to please complete the feedback form afterwards, just to give us your feedback, and then your certificate will be emailed to you as soon as we've received that feedback. I think then we can hand over to Mina to just end off for us.
Good evening, everybody. Thank you all for your attendance. Enjoy the rest of your evening. We will be uploading the presentation, the webinar on the YouTube. Apologies for the technical delay as well.
No.